Thank you so much, everyone, for coming here this evening. For those of you that don't know me, I'm Claire Brenner, the co-founder and CEO of Myogenes. So 7 years ago, I found out what pharmacogenetic testing was, which is looking at the right medication at the right dose for the individual based on their genetics. Genius. So now what do? So I go and I find Professor Sir Munir Pirmohamed, and I phoned him up, not expecting him to answer his own phone, and he picked it up and said, Munir, I was like, and I said, I really want to do pharmacogenetics. And he said, you have to do pharmacogenetics because the NHS are spending, at the time, £1.6 billion. I think now it's up to £2.2 billion every year on people with adverse drug reactions. And I remember you said to me, even you're called the disruptor for trying to get pharmacogenetics into the NHS. So 5 years ago, and I think some of you people here were there 5 years ago, Munir came and did a talk on the challenges and opportunities of pharmacogenetics. And really that's when the Myogenes journey began. And over the last 5 years, Myogenes have worked tirelessly to try and show the benefits of pharmacogenetics. We're doing a huge trial with Munir and Liverpool University to show the positive outcome, not just of the financial, but also for the positive patient outcome, which obviously for us, that's the most important. We've also, Myogenes, with Professor David Taylor at the Maudsley, have developed a test for clozapine, and we're banging on all those doors, thick walls, very, very hard. We're now in 8 of the 54 mental health trusts. And as you probably know, that there's about 30 million people on antidepressants, and over a third of those won't respond to their first, their second, their third line of medication. So Myogenes, we are focusing on the mental health side. But I could go on and on and on all night because I'm so passionate about what I do and the people that it has helped and the doctors that we work with. But I'm absolutely privileged and delighted to be able to invite Munir back again today to speak about the opportunities, the challenges, the implementation of pharmacogenetics. So thank you so much.
Thank you very much, Claire, and thank you very much for the invitation. It's great to see so many people here. It's a good thing that football's not on telly. Maybe I would have a much smaller audience and so on. So I'm just going to tell you about some of the aspects of pharmacogenomics and how we've moved along over the last 5 years, and the fact that we are really ready for implementation, but what are the challenges and what's preventing us from implementing. So if you look at the medicines landscape in England only, it's huge. The NHS in England sees 1 million patients every 36 hours. And we prescribe 1.1 billion prescriptions in the community at a cost in England only of about £20 billion. And obviously that is important because it brings benefits in terms of medicines that are used, but it also has some downsides as well. One of those is adverse drug reactions, 8,000 hospital inpatients with ADRs, but also loss of medication errors and so on. And if you start breaking that down in terms of efficacy and safety, there's a huge degree of variability in drug response. Alan Roses, who was GSK vice president at the time, gave a talk in London, and he said that 90% of drugs only work in 30 to 50% of patients. Unbeknown to him, there was a journalist in the audience from The Independent, and he ended up on the front page of The Independent the next day. Our drugs don't work in most patients, GSK boss says. I think that was the title. So he had to explain himself to his chief executive the next day, I think. But he was quite right. He was being honest that, drugs don't work in everybody. And as Claire said, with antidepressants, third, people don't respond, they don't respond to second drug, etc., and so on. And with antidepressants, you often have to wait 3 months for a response. Therefore, somebody may have been on the drug for 12 months without any response. That's not good for them, that's not good for the NHS, etc. Safety is another aspect. 6.5% of all admissions are due to adverse drug reactions. That was our paper in 2004, but actually it's probably getting worse, and I'll show you some data on that. And the reason it's getting worse is because of polypharmacy. Polypharmacy is now prevalent in our population. This is a report from Keith Ridge, who was the Chief Pharmaceutical Officer at NHS England in 2021. And his report says that 15% of patients are now on 5 or more medicines, 7% on greater than 8 medicines. And the elderly, those with disabilities, including autistic people, including people with educational needs, and minority ethnic backgrounds are disproportionately affected. And you can see this is not just a phenomenon in the UK, it's a phenomenon that's occurring in many countries, particularly in the Western world, but actually it is starting to happen in lower middle income countries as well, where as we are beginning to treat infections better, people are developing kind of Western diseases there. Now, with this polypharmacy, that is leading to much higher rates of adverse drug reactions. So we published something recently in 2022, and we showed that adverse drug reactions accounted for 16.5% of all hospital admissions. As you'd expect, those with adverse drug reactions take more medicines and have more comorbidities. A mortality rate from that was 0.34%. And 0.34% doesn't seem that much, but actually if you take into account the number of people admitted, then you can do your maths and so on. It comes to a large number. And the cost, when we extrapolate that to the whole of the NHS England bed base, was £2.21 billion per annum. So that's a huge cost to the NHS and so on. And clearly this is going to get worse rather than better, and so we need to think about some transformational ways of being able to improve this and improve outcomes for our patients. So what I'm talking about is variability in drug response. Now, I'm going to talk mostly about genomics, but as a clinical pharmacologist, I have to say that there are many other factors that are important for variability in drug response. Sex, for example. Females have a higher rate of adverse drug reactions than males because more drug development is undertaken in males than in females. We extrapolate the dose that was good in males to females who have a different volume of distribution, and they get adverse drug reactions. And there are diseases, concomitant diseases, renal function, etc. But at the moment, what we do, and I'll come back to that at the end, is that we look at binary factors. We look at one thing, and we then say we want to change the dose based on that particular factor. But actually, the patients I see and you see have more than one factor at a time. They not only have the renal disease, the polypharmacy, the drug-drug interaction, but they also have genetic polymorphisms. And that's where the complexity comes in, and that's what we need to deal with for the future as we move forward, hopefully in a better way to treat our patients. So what is the definition of pharmacogenetics? So on screen is Friedrich Vogel, who was a German pharmacologist in 1959, and he coined the term pharmacogenetics, not genomics. And this had various definitions: study of variation, DNA, RNA characteristics as related to drug response. In 1997, the term pharmacogenomics was coined by Marshall, the editor of Nature Biotechnology. I wrote a review for Nature Reviews Genetics earlier this year, and I said I wanted to have a broader definition of pharmacogenomics, one which correlated with what Friedrich Vogel said, that is to optimize drug dose and choice of individual patients to maximize efficacy, minimize toxicity. But we can also use pharmacogenomics for drug discovery, identify new drugs. We have about 19,000 genes in the human genome. 25% are said to be druggable. And of those 25%, 75% haven't been drugged yet. So there's huge opportunities to identify new drug targets based on genomics data. So if you look at pharmacogenomic variation, it's very common. 99% of people will carry at least one actionable genotype. So all of you in this room will have at least one. Most of you will have 4. genotypes, and some of you will have about 7 or 8 genotypes which are important for you. So it's very common. It's not something that is rare in the population and so on. So we should be looking at that in everybody as part of the variability. And just to sort of explain that, we've been doing this work with the polypharmacy cohort, and this is something that we're working with Claire on as well, and looking at people who are admitted with 5 to 8 medications here, and then, is that coming up on there? No, it's not. 5 to 8 medications and 9+ medications. When you start cleaning up the data, some of the medications go down, some of the medications go up and so on, but you can see the total number of medications that have been taken by this group of patients. And they're all admitted to the hospital, and we're following them up through electronic health record of appropriate consent. We then went on to, thank you, is that showing up now? Yeah, great, thank you. We then went on to look at the CPIC guidelines. CPIC is the Clinical Pharmacogenetics Implementation Consortium guidelines. And I've worked with them and done a few guidelines and so on. And based on those guidelines, we were then able to look at what particular drugs they may have been taking and how many potential pharmacogenetic variants they have, some of the genetics that we've done on them. And what we found was that majority of people were on at least 2 drugs where there's actionable pharmacogenomic guidance available at the moment. When they're on 5 to 8 medications, and when they're on 9+ medications, a median of 2 drugs again. But look at that, some people were on 6 drugs where there was evidence of pharmacogenomic variation. And even in the sort of 5 to 8 medication cohort, some individuals with 4 drugs where there was pharmacogenomic guidance. So pharmacogenomic variation is common, and we are commonly exposed to pharmacogenetically determined drugs in terms of response. So I'm going to take you through 3 examples with distinct issues, some of the issues that people have had with implementation, on some of the sort of dangers of not implementing as well in this. So let me start off with the first one, which is clopidogrel. Clopidogrel is an antiplatelet drug. It's very widely used, and randomized controlled trials have shown that it's effective in preventing thrombosis, preventing strokes, things like that. But it's a prodrug. That means it's broken down in the body, in the liver, by this particular enzyme, cytochrome P452C19, to form an active metabolite. The active metabolite then goes and binds to platelet surfaces and causes inhibition of platelet aggregation. Now, one would have thought that one would need to be able to do genotype for 2C19 before you gave patients clopidogrel, and if they were poor metabolizers, then you should give them something different. That would be the hypothesis. And that's been shown in very many observational studies, and there's been recent randomized controlled trial data in coronary artery disease. But if you talk to the cardiologists, they don't believe in it. And you know, it's still not in major guidelines. It's not in the American Heart Association or European Society of Cardiology guidelines. But interestingly, there's great acceptance by stroke physicians. And this is now the main area of implementation in the UK. And NICE recently has approved CYP2C19 genotyping for the stroke indication and TIA indication, but not for the cardiac indication. And that's important because there are many patients who come in with strokes who are then given clopidogrel and, you know, unfortunately may come back in, and we don't know whether that's related to the 2C19 polymorphism. But here's some examples of that particular cohort I showed you before. And if we focus in on clopidogrel, there were 52 patients in this cohort who were receiving clopidogrel. 11 were either poor or intermediate metabolizers of clopidogrel. And so 11 people there out of the 52 should not have been clopidogrel. They should have been on a different drug to prevent them from getting strokes. And so what we're looking at is following them through electronic health records to see whether they had a higher rate of strokes and things like that. And there's the other issue of ethnicity. We at the moment treat everybody in the same way, but actually ethnicity is a really important determinant of how frequent the polymorphism is in that population. So if you look at the populations across the world, you find that particularly in Southeast Asia, the frequency of this particular polymorphism is much higher. So therefore, patients of Indian background, patients of Chinese background will respond poorly to clopidogrel, more likely to respond poorly to clopidogrel because of that they have a higher frequency of this polymorphism. At the moment, we treat everybody with the same drug, one drug fits all, one dose fits all. And this can have unintended consequences. So in Hawaii, there's a big Polynesian population. And the frequency of the SUC19 polymorphism is very high in Hawaii. And the Hawaiian government then felt that clopidogrel was not being used properly, looked at the label, and then they sued the company, Bristol Myers Squibb and Sanofi, who were the marketing authorization holders, basically saying that they didn't provide good enough information in the label to warn people about the fact that the polymorphism was much more frequent, and therefore people with polymorphism may have poorer outcomes. And they won the case in the American courts with £834 million damages awarded to the Hawaiian government. Now, the company's, I think, appealing, and I don't know what the sort of, when that appeal will be heard, but nevertheless highlights some of the legal issues that are being faced by companies at the moment, but also by individuals as well. And as pharmacogenomics becomes more, there's more data on that, more evidence, then it is likely that patients will start suing doctors as well, saying that actually I've done this and you didn't actually test me for this and found that there was a problem. But I just want to highlight that it's not just pharmacogenomics. There are clinical factors we need to take into account as well, and that complex diagram I showed you. So again, let's look at 2C19. So this is a paper which has just come out in Nature Communications. And what they did was to look at non-alcoholic fatty liver disease. And what they were able to show was that there is decreased messenger RNA and therefore decreased enzyme of cytochrome P452C19 in patients with NAFLD. And then they confirmed it by meta-analysis in 16 other studies. And the decrease is about by 43 to 58%. So being overweight, having a fatty liver, reduces your cytochrome P452C19. So it's like having a polymorphism. One of your genes has that polymorphism. But if you're already a poor intermediate metabolizer, your polymorphism is already reduced, your activity is already reduced, then if you gain weight, your liver becomes fatty, then you basically lose all activity of 2C19 and highlights the interaction between your disease and the genetics and so on. And we already know that NAFLD patients have been shown to have reduced effect of clopidogrel in the past. There have been studies which have shown that. But actually, when you look at NAFLD trials on clopidogrel, NAFLD patients were often excluded from the trials. And what we do at the moment is that we undertake trials where we exclude people with certain diseases from those trials. So generalizability of trials can sometimes be difficult. My second example of dose is on warfarin. Warfarin is still a widely used drug, anticoagulant worldwide, perhaps less so in this country now. I'll come to that in a minute. And many people, including ourselves, were able to show there are two particular polymorphisms which are important. A gene which is involved in the metabolism of warfarin, which is called cytochrome P452C9, and a gene which is inhibited by warfarin, vitamin K epoxyreductase complex. And these two genes account for 40% of the dose variation in warfarin. But there are sort of clinical factors, age. As you get older, your liver gets smaller, something for all of us to look forward to, and you need less warfarin. As you get heavier, you need more warfarin, etc. So we actually developed an algorithm. And the algorithm actually was the first example, one of the first examples in pharmacogenetics of a polygenic risk score. You'll have heard of those now. Quite fashionable. And this polygenic risk score accounted for about 58% of the dose variation. And people said, well, actually, you've developed an algorithm, very nice maths and so on. What are you going to do with it? Well, we went on to do a randomized control trial, which we did in the UK and in Sweden. And this was published in the New England Journal of Medicine. And we were able to show that genotyping prospectively was able to improve the control of anticoagulation warfarin compared to standard of care. Then people said, well, that was a randomized control trial. It won't work in the real world. So we did an implementation study whereby we had a point of care test, which allowed you to be able to get the genetic test in 45 minutes. And we then trained nurses and pharmacists in the anticoagulant clinics to be able to do the genotyping as the patient came in. And they were able to do that, and they were able to show that actually the sort of point of care genetic testing in these individuals, in these clinics, was able to improve anticoagulation control with warfarin compared to clinics which weren't using it. So that's good news that we were able to do the clinical utility and randomized control trials and implementation. We were able to show that. But we also did a questionnaire, and we asked, how did you find the genetic tests from the nurses and pharmacists? They said it was fine, but only one thing. It increased the length of our clinic because your patients had to wait for 45 minutes for the test result to come back. And they didn't like that because they were going home later and so on. So that's a problem. So since then, there's been a lot of data on warfarin pharmacogenomics, but it's never been implemented in this country. First thing is that it's often difficult to change clinician behavior. People say, well, I've been using warfarin for many years. I know how it works and so on. I've never seen any problems with it and so on, so I'm not going to change. And people have also said that INR, international normalized ratio we use, is adequate. But international normalized ratio does not prevent the high peaks that we sometimes get, particularly at the beginning and so on. And genetics is important for the first 12 days of warfarin. It's not particularly important later on, but the first 12 days are often critical. When we published our paper in New England Journal of Medicine, which was the EU PAC trial, the Americans also published something called the COAG trial in the same journal at the same time. And they showed no difference of pharmacogenetics. And the large reason for that was that 27% of the people in the American trial were African-American background. And the genotypes in those African-Americans are different than those seen in Caucasian individuals, and they didn't type for those particular variants. So those African-American individuals were being overdosed, and therefore that negated the beneficial effect of warfarin. So there's no recommendation clinical guidelines at the moment. People say there's lack of available genotyping platforms, but those are available now. But in the pandemic, what happened was that we didn't want to see patients and reduce contact, isolation, etc., and so on. And there was the NHS felt that everybody had to be moved to DOACs. So everybody's now on direct oral anticoagulants, and warfarin is used in certain areas and so on. But where it is used, we still don't use any pharmacogenetics. The other thing that is important is there's lack of diversity in data on warfarin pharmacogenomics in this country. When I developed the algorithm, it was developed in a Caucasian population. If an Indian patient or an African patient came to the clinic, we couldn't use the same dosing algorithm because it wasn't tested in that particular population. And that has a tendency to exacerbate health inequalities. So let me just move on to safety. And we've been interested in very serious adverse drug reactions, such as toxic epidermonecrosis. So this is a patient that I looked after in my hospital. The patient had an anti-epileptic drug called carbamazepine. For 2 weeks, after 2 weeks, they developed a rash. Then this rash progressed to blistering. At the peak of the reaction, 60% of the body surface area was blistered. So that's like having third-degree burns affecting 60% of your body surface area. The mortality in that situation is 1 in 3. And we've been interested in the HLA region to see whether these reactions, which are immune-mediated, and there are predictors in the HLA region, which you can then utilize to be able to prevent these kind of serious reactions. And so since the beginning of this century, and we're only 23 years into the century, there have been at least 30 different HLA associations with different serious adverse drug reactions. And they can occur in every part of the HLA. In class 1, as A, B, C. In class 2, DRB, DRQ, etc. And they can affect almost any drug. You can see the different drugs that are here, different therapeutic classes. and they can cause many different types of serious immune-mediated reactions. So skin reactions that I showed you, liver injury, bone marrow suppression, muscle injury, etc. So it's important that we are finding these predictors of these serious reactions. However, even though we have those predictors, implementation has been difficult. So if you look at carbamazepine, the drug I showed you before, with that patient who had toxic epidermocrosis, so there are two particular genes which have been identified, HLA-B star 1502, and this has now been replicated all over the world, and cohort studies have shown that if you genotype beforehand and then you avoid carbamazepine in those people who got this allele, what happens is that you do reduce the incidence of SJST and the serious reaction. In Caucasian individuals, HLA-31 is more important, while HLA-B1502 is more important in Southeast Asian individuals. Again, been replicated and been shown to have utility. And we've written a guideline on this, saying that everybody who goes on carbamazepine should have genotyping for HLA-1502 and HLA-3101. However, that doesn't happen in practice. And if you look at HLA-1502 and look at it in Southeast Asia, where there's a lot of evidence of its utility, these are 3 studies in 3 countries, Hong Kong, Taiwan, Singapore. The government said, we've looked at the evidence, we believe in the evidence, we want all doctors to do genotyping before you put anybody on carbamazepine. We'll pay for the genetic test. What did the doctors do? The doctors decided not to do the genetic test and decided not to prescribe carbamazepine, and they prescribed other drugs, such as phenytoin, etc. And what happened was that the overall incidence of Stevens-Johnson syndrome did not change. It went up because people were getting phenytoin, lamotrigine, etc. Where they did do the genetic test and gave carbamazepine, the incidence of carbamazepine-induced SGST went down. Similarly, in Taiwan, the use of carbamazepine decreased because genetic tests was interfering with the normal clinical pathway, and they didn't like doing genetic tests. Similarly, in Singapore, genetic tests were not liked. So that's the way, again, about changing behavior. Even though there is evidence, etc., because it doesn't fit in with your clinical pathway, people avoid doing it. So we've been seeing how we can actually try to implement pharmacogenomic testing for HLA. And this paper, which has come out from South Korea, used pre-stored HLA information from transplant recipients, and they looked at all these different HLA alleles which have been associated with serious adverse drug reactions. And they had about 12,000 HLA-tested transplant recipients. 34% had high-risk alleles. 34%, 1 in 3, so which is quite high. And 38% of those prescribed high-risk drug, and about 5% developed these serious immune-mediated reactions. And what they were able to say was there's availability of preemptive HLA information that has a potential to prevent serious hypersensitivity reactions. And we've worked to develop an HLA allele panel. This was funded by the National Institute of Health Research, and we worked with a company called MC Diagnostics to develop it. And here, what we've done is to be able to develop this panel, which contains 24 HLA alleles, but it can actually be increased. It can also dynamic. You can change it depending on new evidence that comes through. And the idea is that if you need to do this, if you're going to prescribe somebody carbamazepine, you may do this first time for the carbamazepine, but actually get a lot of other data you can store on your electronic health record. So as the patient gets older, requires another high-risk drug, you already have that information on your electronic health record. At the moment, if I want to do HLA testing in my hospital, I have to do single locus testing. It takes about 2 weeks to get the results back, and the cost, I'm told, is between 100 to 150 pounds to do that test. However, what we did with this test was to make sure it was much cheaper than single locus testing, and we were also keen to make sure the turnaround time was short, 48 hours. I talked to neurologists before. If I was going to introduce this for carbamazepine, how quickly do you want the test result? They said, if you give it to me after 48 hours, I'm not going to be interested. So we had a 48-hour turnaround time, and we managed that and so on. And so this test is now CE marked and so on, and it's implemented in certain labs. So implementation, I think, is really important, and I've shown you the evidence that we have, and evidence that's been building up, and some of the challenges with implementations that already occurred. And if you look at implementation worldwide, there's lots of implementation going on in different parts of the world. There are 40 distinct programs. 95% of those are in high-income countries, mostly in the United States. There are a few going on in the UK, a few in Europe, particularly in Netherlands, and so on. Okay, but very little going on in the lower middle-income countries. And I was keen to be able to interact with clinicians, to be able to see how we can start implementing pharmacogenetics. So I worked with the Royal College of Physicians of London and the British Pharmacological Society, and I chaired a working group. And this represented, I guess, the Royal College of Physicians represented 26 medical specialties, but we didn't limit ourselves to the Royal College of Physicians. We had representation from the Royal College of Psychiatrists, Royal College of Anaesthetists, Royal College of General Practitioners, and from pediatrics as well, and from the Royal Pharmaceutical Society as well. And this report, Personalized Prescribing, was published last year, and the recommendations are shown here. And we felt, and this was endorsed by the Royal College of Physicians, 26 medical specialties, that we now have enough evidence to implement pharmacogenetics in all sectors. That is in primary care, secondary care, tertiary care. We also felt that this should be centrally funded, because unless you can centrally fund it, what will happen is that some people who can afford it will get the pharmacogenetic test, while the deprived populations, who are often the most affected by multiple polypharmacy, etc., will not get it, and so on. So that's really important. We also said they need to be agile. Pharmacogenomic advances are happening rapidly, so we need to be able to improve what we include within our panels and so on as we move forward. We also said that what we should do is panel testing, not single locus, but panel testing. You do the test for one gene, but you keep the results for the later, so you don't have to keep on repeating the test. Unfortunately, there's a massive skills gap in our workforce, and there needs to be a comprehensive education training package associated with whatever we do. The other challenge is actually how do we support the clinicians? A general practitioner, I think, has between 8 to 10 minutes to see a patient. As a consultant, I probably have 15 minutes to see a patient in my clinic. And if somebody gives me 3 billion data points and says, look at this 3 billion data points and so on, and do it in 15 minutes and make the right decisions, that's not going to happen. So we really need good, intelligent decision support systems to be able to help us, to be able to really make sure that the clinical pathway remains as simple as possible. It's there at the point of need in order to be able to implement pharmacogenetics. Clearly, there's many other drugs there where there is quite a lot of work need to be undertaken to be able to look at pharmacogenetic predictors in combination with clinical factors. I keep mentioning those again. Most importantly, there needs to be clear line of communication, not only with healthcare practitioners, that's doctors, nurses, pharmacists, but also particularly with the public, patients and the public. There are many benefits to pharmacogenetics, but there are also limitations to pharmacogenetics. It will never be 100% predictive, but actually at the moment we may be predictability of less than 10% for most drugs, but actually if you can increase it to 50, 60%, that actually helps in terms of improving clinical outcomes. It's not a panacea, but it is information, and all information can be valuable in terms of determining how we treat patients and how we improve the care of patients. And in order to be able to do this, we know we've been doing further work and so on, and one of the things that I was involved in was the PREPARE trial. It was published in the Lancet earlier this year, so I'll just tell you about the PREPARE trial. This was funded by the EU Commission, and it started in 2016. And what we wanted to do as part of this Ubiquitous Pharmacogenomics Consortium is to undertake a cluster randomized study, whereby there were 7 centres across Europe. Liverpool was the only UK centre. And these 3 centres here started on pharmacogenomic guided prescribing, while the other 4 centres started as standard of care. At 18 months, this was a 36-month study, 18 months we stopped over. So pharmacogenomic guided prescribing became standard of care became pharmacogenomic guided prescribing. And what we wanted to do was to follow patients up who would receive pharmacogenomic guided prescribing and standard of care and see whether there was improvement in outcomes. And this was a hugely complex study. I was funded for 2 people by the European Commission, but in fact I eventually ended up having 8 people working on this, trying to find resources from elsewhere so that we could actually do this study properly. So patient recruited, DNA sample, results back to the notes of the patient within 7 days. The record is in the electronic medication record. If there's a polymorphism, we inform the doctor or the pharmacist that there was a polymorphism in this patient and they were on a particular drug, but we didn't mandate a change in the drug or dose. We just left it to them. So, some people didn't want to do this, and some people did want to do this, and I'll come back to that a bit later on. And the guidance we used was Dutch Pharmacogenetics Working Group Guidelines, which is similar to CPIC, actually very good correlation between them. And we followed up the patients at 2, 4, 8, and 12 weeks, at face-to-face follow-up, 4, 12, etc., end of study, and online follow-up at 2 to 8 weeks. So it's quite complex and very intensive for the patients and as well as the nursing workforce who did this. Every lab had the same genotyping platform, all 7 labs, and we looked at 12 genes that contained 44 variants, and that looked at 39 drugs which are widely used in the European healthcare system, including the NHS. Every patient got a pharmacogenomics card, which has a QR code on it. And you can scan the QR code with your iPhone or Android phone. It takes you to a website which tells you what the genetic data is for that particular individual, together with guidance on what to do based on the polymorphism. Now, if you're looking at 39 drugs, you need to have a primary endpoint, which every drug can, you can sort of look at for whether any drug or any of those 39 drugs is having an effect. And what we chose was adverse drug reactions as the primary outcome measure. So we looked at all adverse drug events which are occurring. Adverse drug events are adverse events which are occurring irrespective of causality. And we weren't interested in adverse drug events, we were interested in adverse drug reactions. So what we had to do was then to filter down. The first thing we filtered for was severity. So we excluded all grade 1 adverse drug events, and we only included grade 2 to 5 adverse events. Then what we want to do is to convert the adverse events to adverse drug reactions, and we did a causality assessment on every patient in every center. And we used something called the Liverpool Causality Assessment Tool that we developed, which was a validated tool. And only when somebody had a possible, probable, or definite adverse drug reaction did we say that they had an adverse drug reaction. So this is what we did for recruitment. In the first block, we were going quite well, 3,581. Our aim was to recruit 8,000 patients altogether. And we were progressing and were going to hit the target, but unfortunately COVID happened in February 2020. And we couldn't get into hospitals, we couldn't really sort of recruit, and all studies, as you know, in the UK were stopped, only COVID-related studies were going on. So we really couldn't recruit after February 2020. So we had to curtail recruitment. But despite that, we managed to recruit almost 7,000 patients. And following that, we've been working, we had been working into trying to do various different things, including the sort of cleaning, severity causality assessment as well. But also, we got the Netherlands regulatory agency called LAREB to be able to do an independent assessment on the causality assessment that we'd done on 10% of the individuals to make sure that there was no bias introduced in terms of what we were doing. So this is what we ended up with. There were some patients lost to follow-up, and we ended up with 3,270 patients in the control arm and 2,923 in the study arm. And from that, we were then able to divide the patients up into those who had an actionable drug-gene interaction and those who had no actionable drug-gene interaction. Basically, 22% of the individuals had an actionable drug-gene interaction, which is what you expect from the literature. And as I said, this was published in the Lancet earlier this year. And when we looked at the actionable test result, which was a primary analysis that we'd pre-specified in our protocol, that showed that that reduced the adverse drug reactions by 30% with an odds ratio of 7.7. However, our pre-specified protocol analysis plan said that we would do a gatekeeping analysis. That is, that we would do the primary analysis in the actionables, and then we would do a secondary analysis in all patients, which would include the non-actionables as well as the actionables. And when we did that analysis in the non-actionables as well, we got exactly the same result, a 30% reduction in adverse drug reactions. So that was interpreted by some people in the literature saying that this showed that pharmacogenetics doesn't work, that this was just a placebo or nocebo effect. But what they didn't look at paper in depth and so on, and maybe we should have explained it better, so it's our fault probably. But actually what we had was an implementation study. It wasn't a randomized control trial. And if it was a pure randomized control trial, you know, you'd expect the case mix to be exactly the same in both arms, in the control arm as well as in the test arm. But this was an implementation study. So things were changing. We were adding more centers. We were adding more drugs and so on because new evidence came through. So we had to keep up with the guidelines and so on that were changing. And so, in fact, there was a difference in case mix when you looked at the case mix between the two arms. And when you do a statistical analysis of that, and this was a post-hoc analysis, where we did an indexed drug by country interaction analysis, we found that the effect decreased from 0.3 to 0.13 in all patients, but actually increased in those with the actionable genotypes from 0.3 to 0.39, highlighting that this was a true genetic effect rather than a placebo or nocebo effect. And this is largely because of the case mix and confounding effect of case mix. But you know, this has never been done before, and at least it shows us that actually if we're ever going to do studies in the future, that we need to think about how we can control for the case mix. Some reflections on that huge study. It is a huge study, very complex study, and so on. Some people have said, well, you've got a very large effect size, 30%, that seems a very large effect size. But actually that's not surprising because all the gene-drug interactions that we included on the panel have already been highlighted before in previous clinical guidelines. So where there's been shown to be positive effects clinically. So you would expect a large effect size, and that's what we got. Some people worry that this is going to affect efficacy because we were reducing dose in some patients. Actually, the dose reduction is based on PK. It's not based on dose, it's based on exposure. So even though you reduce your dose, your exposure is exactly the same because you've got that genetic polymorphism, so your efficacy shouldn't be affected. Now, I told you that this wasn't mandatory for the doctors to implement this. 70% of prescribers adopted the recommendations, 30% did not. And if all 100% had adopted the recommendations, we'd have got an even bigger effect. And as I said, the test results are available within 7 days. And unfortunately, you know, some people had already developed the side effects by the time they got the test result, because people developed adverse effects earlier. So we probably missed, you know, some of the benefits of pharmacogenetic testing, and hence why a preemptive approach, i.e. having the genetic data beforehand, would have helped. And some people have criticized that we accepted grade 2 and 3 adverse drug reactions, which are said to be mild or moderate. But actually to the patient, is the mild and moderate as just as important as the severe adverse drug reactions. Because if they have a mild adverse drug reaction, they stop taking the drug because they're getting the side effects and so on from it. So it's really very, very much patient-orientated what we did rather than doctor-orientated. I remember as a senior house officer going to see a patient saying, I'm really worried about your liver function tests, you know, with these drug and so on. It was about 5 times upper limit to normal. And she said, okay, doctor, well, I'm feeling okay. But actually, doctor, I've got really bad constipation. I'm much more worried about that, right? And that was we categorized as a mild adverse drug reaction that she had. And that tells you what patients have a different perspective, so we need to take into account the patient perspective. So lessons from this, if you're going to implement pharmacogenetics into practice, obviously you need to order a test. You need the laboratory infrastructure to undertake the test. You need reporting the result back to the reporter, and you need correct interpretation of the result and appropriate action with the particular index drug. A key aspect, I think, that we need to think about is turnaround time. Now, this will vary with drug-gene pairs that we look at. For some point-of-care testing we required, as I said, for warfarin, we had a 45-minute test. For 2C19, for clopidogrel, particularly when people are doing angioplasties and so on, or putting stents in, there is a point-of-care test. And Bill Newman and John McDermott in Manchester have shown the importance of point-of-care testing in neonates in preventing aminoglycoside-induced deafness and so on. So, as I said, for the HLA panel, we looked for a 48-hour turnaround time. But perhaps most results should be back within 5 days. That's what we aim for DPYD, which is used in cancer at the moment. But for some drugs, a longer time may be acceptable. But the problem is that a longer a prescriber waits, the more likely they are to lose interest or not bother requesting the test at all, just as I was told by the neurologist when I started. Another issue is that laboratory capacity. Now, nearly 500,000 people or more adults in England have antidepressants. And between 2021, 2022, there was a 5% rise in number of adults being prescribed antidepressants. So that's a huge increase every year in terms of people getting antidepressants, maybe 400,000 people every year getting new antidepressants. So that means if you're going to do pharmacogenetic typing on 400,000 individuals just for antidepressants, that's 400,000 new tests every year. And do we have the lab capacity in the NHS to be able to do this? And so how do we actually cope with that? And how do we democratize genetic testing? And we did that in COVID, but how do we democratize that genetic testing and so on? And who's going to pay for it? That's other problem. So the ideal thing would be to have preemptive pharmacogenetics. It is much more efficient than reactive and fits in better with the existing clinical pathways. Then people ask, when should we do this preemptive pharmacogenomic testing? Well, it could be the first time you prescribe a medicine with pharmacogenomic guidance and keep the rest of the data on your electronic health record and make it available. But some people have said maybe we should do it at a certain age. Perhaps when you turn 50, you have a pharmacogenomic test done and you keep the data on the record. And as you get older, you need those drugs and so on, you have the pharmacogenomic testing. But actually, there is a newborn genome sequencing pilot going on at the moment in the UK. 200,000, I think, babies born will be sequenced at birth. And the pharmacogenomics data will be available from them. And in the future, everybody will have a newborn genome sequence, so that will be available. The critical question we need to ask is, how do we assess the utility of the pharmacogenomic testing we do over the long term? And really, that requires electronic health records, follow-up through electronic health records to be able to look at benefits as well as any adverse outcomes and learn from that and try to improve the benefits for our patients in a kind of learning health cycle. So I talked about decision support systems. And decision support systems are not there yet. We need decision support systems to be intelligent. And intelligent is one of those things. We don't want too many alerts, because if there are too many alerts, you switch them off and so on. We want the decision support systems to be interpretable in terms of the information they give to the prescriber. Interpretable so that they can understand it and do the right thing. There are so many different computer systems in the NHS, they need to be interoperable. So you can move it from one particular computer system to another. It needs to be integrated in the electronic health record, which is really important. It needs to be inclusive in terms of place, not only in the rich parts of the UK, but also in the poor parts of the UK, not only in the teaching hospitals, but also in the district general hospitals. And needs to be impactful, and we need to be able to assess the impact of it in terms of way. And those 6 I's have not been fulfilled for any decision support system at the moment. But we need to start somewhere. You can't have perfect be the enemy of the good, and so we need to start somewhere and improve iteratively as we move along. So what I've told you actually is nothing new. There are people who've been around for, or were around centuries ago, who actually said all of this. So Hippocrates said that it's the what sort of person has the disease than what sort of disease the person has was much more important. Paracelsus in 1500 said that dose is either remedy or poison. Well, we haven't learned from that in 500 years. And Osler in the early 1900s said variability is the law of life. And variability is the key determinant of poor quality in our clinical care. And we don't take that into account in terms of improving the quality of clinical care. So let me finish off. So I'm a clinical pharmacologist and I do pharmacogenetics, and what we try to do is to improve the benefit-harm ratio of medicines. And we need to deal with complexity. Pharmacogenomics is just one component of that. I've shown you all the other aspects in terms of the age, sex, drug-drug interactions, renal function, dysfunction, etc., and so on, which are all important to take part into account when we deal with the complexity. And as I said, at the moment, we only deal with one factor at a time. And that's, we need to move away from that. We need to deal with the complex factors which are coming through, and the development of multimodal algorithms in the future. And there are technologies out there which we can do that now. And we need to be able to develop that and integrate that, take into account how we treat the patients. And clearly, new technologies are going to help us to deal with this complexity. AI is going to be important in trying to improve that. Genetic factors, we were talking about avatars, digital twins, incorporating that into digital twins will be important. I think in the future, most people will be wandering around with an iPad or equivalent with the patient's genome data, the patient's pharmacometric data, AI embedded, and basically saying this is the best drug for you. Kind of Star Trek medicine, but that may take us, many more decades to get there. And I think that also says that what we are doing is in changing the way we practice medicine. Medicine has always been a very hierarchical relationship between the patient and doctor. But I think it needs to move away from the hierarchy to much more partnership approach. The patient needs to be very much involved in the care of their own care. They should be holding their own data on the NHS app, for example. And so they can show it to all the doctors that they see in different healthcare settings. So I'll finish there and say thank you to all the people I work with, but also the people who have funded us through some of the work that we've undertaken. So thank you very much for your attention.